asking Narasingan some doubts. He'll try to answer, and also the people on the floor also can help. Venkat said the BP target in a diabetic, but so much confusion, Narasingan. One body says 140 by 90 target, other fellow says less than 130 by 80. You're all confused. What to do now?
I think one needs to concentrate mainly on the threshold beyond which one should concentrate on the definition of hypertension. You look at the data coming out from various guidelines. In fact, it was 160 some years ago by JNC 5th, brought down to 150 later, then 140. 140 we were staying at that stage for a number of years. JNC 7 started propagating the same message. European Society of Hypertension, European Society of Cardiology again endorses the same thing. The International Society of Hypertension also tells you that 140 and above 90 should be considered as hypertension. Hypertension Society of India also considered the same level should be considered for treatment. But what happened in between this 2015 to 2023? American College of Cardiology and American Heart Association had joined hands with 10 organizations. Nearly 11 organizations had come to the conclusion that the systolic blood pressure has to be brought down. So 130 and 80 is considered as hypertension. In fact, when they introduced this, a lot of criticism in even United States. 14.8% of the people in the United States became hypertensive.
Currently, the farmer driven. See, so 130 by 80. So half of the world population become hypertensive. Yeah. Don't you think so? No. The question is very simple. When you put 140/90, it is 30%. When you put 130 by 80, it becomes 60%.
Yeah. In
Lakshmanan,
fact, there are
jokes apart. Would you like to have the target of 130 or 120 in some select patients? For example,
we are coming.
Proteinuria.
We are coming.
No, that I think he is going to ask. No, why I started talking like this, every time people say 140/90, I think we should probably think about the problem of pre-hypertension, which was actually coming out from JNC 7. 120 to 139, 80 to 89 is considered as pre-hypertension. The same group is now divided as one elevated hypertension and stage 1 hypertension. You go to stage 2, propagated by ACC/AHA, 140/90. If you say 140/90 applicable to Indians, that means stage 2 of Americans recommendation. I think we should revise our approach to people with hypertension, because the incidence of pre-hypertension is very high in our country. The problem of obesity is very high. The problem of metabolic syndrome is high. The pre-hypertension risk of getting cardiovascular risk is very, very high in those people with diabetes. If you take only diabetes, much more when compared to normal people. Normal people getting pre-hypertension risk is more. Diabetes risk is more. When diabetes is associated with the pre-hypertension, the risk is enhanced. So we need to realize that we are having a problem with the pre-hypertension. We need to be very careful. Of course, you need to implement lifestyle changes for the next 3 months or six months. If the fellow is not responding, I think there is a place for pharmacotherapy. So we need to realize that we need to identify people above 130 and 80 that is acceptable even for our country, because there is good number of data. There is one study called Mumbai cohort study, which had evaluated people for the development of cardiovascular risk and mortality. The IHD mortality is much more when the blood pressure goes beyond 130. The stroke mortality is much more when it goes beyond 130. Again, stressing the importance of identifying people above 130. So when the risk is more, when the mortality is more, our own data, Mumbai cohort data, I think we need to accept that there is a problem by facing this sort of individuals with the pre-hypertension. We need
so
to
Narasingan feels that 130 by 80 above should be targeted for BP control. But what happened to the ACCARD BP arm? In a diabetic, it did not show much benefit of reducing.
See, ACCARD study, I think ACCARD lipid arm, ACCARD glucose arm, ACCARD hypertension arm. In fact, no, they had reduced the blood pressure with all sorts of drugs and brought it down less than 120. People in whom the blood pressure was brought down to less than 120, there is no cardiovascular benefit. In fact, the electrolyte disturbances occurred, the problem of cardiovascular risk was very high, Of course, it had helped those people with the stroke prevention. Except for that, we don't get any benefit. So thereby, there is a definite information what we had gained out of this particular study is that ACCORD study had clearly indicated that blood pressure of 120, less than 120 in a diabetic person will definitely push him for an increased risk, including mortality. Because there are a number of studies, even accomplished study has started talking about the J curve. When you keep the levels at 140, the risk is there. When you bring it down to 130, the risk comes down. When you bring it down to 130 to 120, the risk comes down. When it goes down 120, the risk goes up.
That makes an interesting fundamental question to both of you. I'm sure you will agree. Now, when you talk about the sugar, there's always a compelling comparison between blood sugar and blood pressure. See, in blood sugar, you have fortunately a couple of populations like the Nauruans and the PMI Indians, wherein it's a bimodal distribution. You have the population which is clearly diabetic, you have a normal population. So the issue is settled. Of course, you have the other data. Whereas, do you have any data like that? Otherwise, it's a continuous variable. It's a single distribution. So for blood pressure, starts from 90, 100 onwards, there are data to suggest that you have some comorbid endpoints. What I'm trying to say is, are there any relevant reference in the literature with respect to some populations who do have very normal BP, low BP, and people who have got some hypertension with endpoints, so that will be a model for us to strike, to arrive at the target which we can aim in the other populations.
See, that's what the sprint people did.
We need to probably depend on the guidelines what has been published in the recent past. Whatever guidelines you are in favor, probably you can follow that. But unfortunately, many of us don't follow the guidelines. You need to remember that the guidelines are actually coming out of evidence. Where does the evidence come from? It is from randomized control trials, meta-analysis. We need to take that into account and then implement in our clinical practice. There is no point in just arguing all the time, what is normal BP, what is optimal BP, what is high normal BP, what is the stage 1, stage 2, stage 3. A lot of confusion for the Hypertension Society of India. I don't even remember the numbers, but I'm able to remember the numbers given by the American Association, because it was only simple classification of hypertension, definition also. The target, ACC-AHA tells you whatever is the problem, whether diabetic, non-diabetic, with renal disease, without renal disease, with stroke, without stroke, everybody can bring down the blood pressure less than 130. That is 130/80, 130/80 should be the goal all the time, except in two conditions. One, if the atherosclerotic cardiovascular risk as per ACC-AHA calculator is less than 10% in an individual, you can probably start the treatment 140. You can keep it at that level. The second one, if you are going to prevent the secondary stroke in those patients, probably you can keep it at 140. Rest of them, including CKD, 130 should be the goal.
In stroke, is there a distinction between a thrombotic stroke and a hemorrhagic stroke?
Yeah, there is a definite difference.
I finish out the thing. The 130/80 by ACC-AHA came from sprint trial. See, sprint trial looked at the ACCORD BP arm, why the benefits are not there with the diabetic fellows. Finally, they come to the conclusion, the sprint, the diabetic population, they had a very good outcome after 130/80. They say the hypoglycemia in the ACCORD arm mitigates the benefit of the lowering the BP in the diabetic. That was the benefit. And coming to the question of ischemic stroke and the hemorrhagic stroke, I think when a patient has ischemic stroke, never treat the blood pressure for initial 24 hours. That is the real carry-home message. If the patient has got a high blood pressure with ischemic stroke, the outcome is good. People have got a very well tuned. Somebody comes with the BP of 200/120 with the stroke. Just keep the blood pressure intact for 24 hours, unless otherwise you want to give a thrombolytic therapy. If you want to give a thrombolytic therapy, then target the blood pressure from 220 to 160 systolic and 100 diastolic, then give the thrombolytic therapy. But hemorrhagic strokes, a different kettle of fish, you should definitely bring down the blood pressure to 160/100 by any means, because that is very, very important. That's the difference between the ischemic as well as the, but message is that when a patient with a stroke, ischemic, comes with a high blood pressure, he's a candidate who will survive, unlike a candidate who comes with the low blood pressure.
Sir, I just want, if I am permitted.
Yes, sure.
You know, we talk about hypertension every time. What perplexes me is that the blood pressure varies so much, same individual. blood pressure at home, blood pressure in the office, blood pressure while sitting, standing, every time. And the other factors are age, comorbid conditions, so many. How can we actually achieve the so-called strict control of blood pressure? You want to keep it 120 by 80. Are we not going to end up more issues?
There are four things.
Let me just finish, because this is something that I have accumulated over the years. Because this I think is not an easy thing at all. You can easily say 120 by 80. What 120 by 80? Whose blood pressure of 120 80? Where is it 120 by 80? These are all the issues sometimes we are not addressed, although Dr. Narasingan has mentioned about comorbid conditions and other things. So in other words, are the international organizations are also trying to be a little more liberal, in the sense if I read, some of them do mention about 140 by 80, because you're not identifying the age and all, so many things. This is what I want. This is always my concern. I wanted to say that. Thank you.
I think the BP variability, I fully endorse your views. We need to be very careful. It's not like your blood sugar values, you identify it and then HbA1c, then go ahead and treating the patient. Whereas here, once when the patient enters into your room, it's an office blood pressure which you are going to make. What is the instrument that you are going to use for detecting the blood pressure? Are you taking it in the proper manner which is recommended by the academic bodies? Many of us are in this audience are not doing it. The patient should be seated comfortably. All those diagrams are there, which I don't want to tell. That has to be observed. Then the readings should be taken 3 times. And the first one, you can neglect it. This average of the 2 readings, you should enter it. If you are going to concentrate only on the office blood pressure, if it is elevated and if you think that the target organ damage is not there, you can allow the fellow to come after 10 days, after 15 days, again recheck, again do it in the same way, if it is in the office blood pressure. If the fellow is able to bring home blood pressure monitor reading, that gives you a lot of information, just like your ambulatory blood pressure monitoring values. So you may identify whether the patient is really having blood pressure or not. Otherwise, the best way of making a diagnosis of hypertension is only ambulatory blood pressure monitoring. If you use that, probably that will be the best gold standard for you to make a diagnosis. In fact, NICE guidelines in 2011 started telling, if you like to make a diagnosis of hypertension, you should have the ABPM reading. Otherwise, you will be totally wrong. You will be treating a patient unnecessarily. I think the BP variability, what you had mentioned, minute to minute variability, hour to hour, morning to evening, night, everywhere it goes on like that. My BP will be very high because I am worried about Venkatraman, what he's going to ask.
I think what Vasant said, the BP variability, 3 things has to be looked into hypertension. One is the BP variability, nocturnal dipping. The patient dips in bedtime during sleep, early morning surge. All the 3 has to be taken care of. You have to choose a drug which acts on all the 3 parameters in addition to a 24 hours control. So all the 4 things are very important. As you rightly said, if a patient is susceptible for a variability, put him on ABPM. Gives you wonderful information. Now it also says systolic blood pressure, time in range. It's not only for glucose, it's also for systolic blood pressure. People have found out very new concept. The systolic blood pressure time in range at least more than 70% prevents the patient to go for any vascular complications. I think we'll stop with that.
No, I think, can you go on to the molecules? Since you did mention about Lakshmanan, about the nocturnal dipping, are there any preferential molecules which have a say in, for example, the systolic, the nocturnal dipping, absence of dipping, etc.? So can we just have the discussion, the Jugalbandi, focusing on the molecules?
The next question is, Narasingan, will you made a diagnosis of hypertension diabetic, what's your drug of choice? Will you start ARBS or ACI or a beta blocker?
Well, the thing is, if a patient is a type 1 diabetic or a type 2 diabetic, type 1 diabetic with microalbuminuria, without microalbuminuria, only hypertension. The different approach. Microalbuminuria, you need to specifically choose ACI or ARB. The same way, if a microalbuminuria or proteinuria is there in a type 2 diabetes, again ACI or ARB. Otherwise, if the patient with the type 2 diabetes seeks advice, no albuminuria, no coronary artery disease, nothing, blood pressure is associated with diabetes, you can choose any of the 4 molecules, any one, including a diuretic. You need not hesitate to start a diuretic even in a patient with diabetes. Please remember that. And if you are choosing an ARB, why do you always choose ARB? Why not ACI? That's a big question which begs answers from all of us. Can you give any comment on that? Side effect. Not that many. I understand, Karnanidhi, I understand. Only 30% of the patients with the ACE inhibitors get a cough. Rest of them are able to continue the drug. Even for many years, I have been giving perindopril. People are very much better. But they are all.
ACEs are generally, I feel, a weaker antihypertensive than an ARB. I don't know about that.
No, that is only by our own experience people are talking.
But possibly one of the things is the dose that we use. The ACE inhibitors, we always have an opinion that probably side effects are dose related. So that is at the back of our mind. That's one of my
that is right. Even previously when the drugs were introduced, people are giving a 2.5 ml of 5 milligram of ramipril. Take it at bedtime. They don't even escalate to 5. They don't go to 10 milligram, what was proposed in the HOPE study. They never tried, including cardiologists. So they think that it is got a hypotensive effect, first dose hypotension, all this fear was there in their minds. I think we did not use the ACE inhibitors properly. And all the studies which were projected before 2000, I think were only for ACI. After 2001, there are good number of studies only for ARB. Type 1 diabetics actually has shown much more benefits only with the ACI, not with ARB. Type 2 diabetic patients are showing much more benefits only with ARB because the studies are now coming out. For example, irbesartan, which was used in IDNTU trial, reduced the proteinuria. And the telmisartan, which was compared with the ramipril in the on-target study, non-inferior, and it proved that it has got a long action, duration of action. Even the nocturnal blood pressure, what Dr. Venkatraman was trying to talk about it, it reduces the nocturnal blood pressure also. And yet another drug which can reduce the nocturnal blood pressure is the chlorthalidone.
That's what I was asking. Can you utilize this forum to assure our friends about the positioning of the diuretics? Unfortunately, again, probably the literature has been ripe with some unfavorable aspects of the diuretics which is always being highlighted. But the advantage that you have, especially somebody with isolated systolic hypertension, and you have a diuretic, touch a diuretic, beautifully it brings down the BP. So the clinicians have to shut down their inhibition with respect to positioning the diuretics. Would you like to say when do they?
Yeah, 100% I agree with you. Because chlorthalidone has been there with us for the past 60 years. The good old study called SHEP study, systolic hypertension, the elderly program study, which had utilized this molecule compared with the placebo in elderly people. The benefits were seen in all cardiovascular endpoints, and people were followed up for the next 15 years. Surprisingly, people who received chlorthalidone lived for 555 days extra when compared to people on the other arm. So again,
we don't use chlorthalidone much in our population because we live in a hot summer. I've seen people coming with a hypokalemia, use a very small dose of chlorthalidone. But when you take the 24 hours action, when you take the BP variability, when you take the non-dipping morning surge, only 2 drugs, ARBs and CCBs. These are the 2 drugs which really acts on all the 4 parameters. Your beta blocker acts on the morning surge, but not on the dipping.
I agree, Lakshmanan. I agree. Okay, you have started ARB, you have started a CCB, the fellow is not responding, what will you use?
Yeah, then you have to add a 3rd drug, only a diuretic.
Yeah, at that stage you are using diuretic.
But I tell you, now the pharmaceuticals are coming with a combination of ARBs beta blockers. Now selling like a hot cake, which I found it's like a combination of DPP4 plus SGLT inhibitors, 1+1 reduction of the A1C. The BP reduction is very, very good when I use a combination of ARBs and beta blocker. I don't know what indications will you put this drug.
In fact, I will not use a beta blocker as a first line of management for hypertension, irrespective of the matter whether the patient has got diabetes or no diabetes. I will not use it in the 2nd step also. I will not use it in the 3rd step also. I will probably select it as a 4th drug when other drugs have failed to show a reduction of blood pressure. But at any stage, 1st stage, 2nd stage, 3rd stage also, I will use it, provided the patient has got problems like increased sympathetic drive, heart failure, angina, or arrhythmias. If these are associated with that, probably I will not have any hesitation to use this drug.
I think at this point you can also make a mention about the ALHA trial wherein chlorthalidone was used, but unfortunately the beneficial effect was given to the thiazide diuretics. I think that's a point that we have realized later. Now that we are running out of time slightly, I think we have had a beautiful jugalbandi on hypertension. Your favorite topic, Narasingan, dyslipidemia. I think you can initiate the discussion, you can clarify the possible misconceptions about
Narasingan,
dyslipidemia.
what is the LDL target? You people say 30, somebody says 50, other fellow says 55, other fellow says 70. What is going on in the LDL targets?
If you allow me to recollect the data from
Make it very brief.
cardiac study, which had indicated if somebody has a lifelong exposure of LDL to 82 milligrams, the problem of getting a myocardial infarction is at the age of 100 years. If somebody has 122 milligrams of LDL throughout his life, the chances of getting a cardiac event, particularly myocardial infarction, comes down to 64 years. If somebody has 220 milligrams of LDL throughout his life, the problem of getting a myocardial infarction is reduced to 45 years. This is the data which we have got it, number one. Number two, we have seen people with the homozygous familial hypercholesterolemia. They are dying prematurely. Children are dying prematurely due to coronary artery disease. That is indicative of, again, exposure to a long-term exposure of LDL cholesterol more than 500 milligrams. In fact, I have my patient like that. Third one is heterozygous familial hypercholesterolemia. I think we are totally forgetting about this entity called heterozygous familial hypercholesterolemia. The moment the patient seeks advice for a myocardial infarction, if there are no other risk factors, kindly ask the patient's family history. If you are able to catch that, you can even have a cascade screening or a reverse cascade screening. You can identify those people and help them to get rid of all these problems. I have about 10 families of hereditary familial hypercholesterolemia under my care. I think it is time for us to think about that there is a problem of hereditary familial hypercholesterolemia.
I think clinically you think of it when I have a ACUS analysis of the upper cornea.
Yeah.
Number one. Number two, when somebody has got a random LDL of 190, please think about the familial dyslipidemia. Look at the tendons, xanthomas. All that gives you a clue. Family history, rightly said. Somebody has died at the age of 35, 40, premature. So all those things give, it is there, but we are not just looking at, we are missing it.
Yeah, beyond that scope, because he has identified all
The
the
family
quick
history,
come to the target,
what is the
Narasingan.
pattern? It is autosomal recessive or autosomal dominant?
Which one?
The heterozygous familial hypercholesterolemia,
Yeah.
which I think the phenotypic features Narasimhan has nicely highlighted. When you have the pedigree chart, you ask them to follow, I mean, which is the one? Is it autosomal dominant or autosomal recessive?
Dominant. That's not recessive.
It is dominant.
Yeah.
So, you tell the targets quickly. What target?
Yeah. He was asking about the targets. I think I don't know how many people are trying to look at the LDL to start a statin. If you are a diabetologist, please tell me.
I think we
How
can
many
have
of you are targeting or looking at the LDL to start statin?
Yeah.
If all the time.
But it is a comorbid condition, not be a disease. If he is a smoker, then your target should be.
Okay.
It is not individual. If the person has got, if he is a smoker, if he is sedentary lifestyle, then you have to be more aggressive.
My other way of asking is that, how will you identify the atherosclerotic cardiovascular risk in a diabetic individual? Is it based on a lipid profile or not? One of the things.
No, I think his message is, do not just go by a total cholesterol and triglyceride. You need to have a LDL cholesterol estimated, not calculated, estimated.
Yeah, good. Yeah. Will you advise your patient to go for a fasting lipid profile or a non-fasting lipid profile? No. The things are changed now. It can be done at any stage. Non-fasting lipid samples are equally good when compared to fasting. So I have stopped doing it. I have stopped doing it for the past 7 years. That it was.
But triglycerides, because we did a study in Apollo for one of the products. So the difference between the fasting and the non-fasting triglyceride is very high. In fact, it is threateningly high. So I almost asked them to stop doing the triglyceride
Maybe
and
our
the
studies are
non-fasting.
like that. But can I quote one study on this context?
Please. No, we want to learn from you.
Yeah. The thing is, there is one study which was conducted in the United States, 1 lakh population of adults, males, females, children. They have analyzed the fasting sample and the non-fasting sample. The difference was only in triglyceride, 26 milligrams. Only 26 milligrams.
Absolutely. Plus the
26
insulin resistance,
26
maybe.
milligrams. But even if
Narasingan,
you
target.
allow some allowance.
Tell the target, please. Do not come to the conclusion at all. Make it
Okay.
fast.
You want the target. Okay. So depending on the person's problem, for example, a diabetes with no atherosclerotic cardiovascular disease,
Make it very brief.
and only one or less than one or no risk factors is a diabetic. You try to keep the level 100. If the same diabetic, no coronary artery disease, and there is no albuminuria, nothing, no other problem, but two risk factors are operating. For example, hypertension is a smoker. That means you need to keep the levels again less than 100, preferably less than 70. Person is at a high risk with the problem of increased cardiovascular risk based on the duration of diabetes, smoking, this, that, and we have divided in such a way. You can keep the levels less than 70.
Already he had one event.
Very high risk, atherosclerotic cardiovascular disease, myocardial infarction, diabetic, keep the levels less than 50. If the person with a coronary artery disease also has got a peripheral vascular disease, polyvascular disease, more than 3 risk factors are operating, plus he is a smoker, that means he requires less than 30 milligram, as per the recommendation given by Lipid Association of India.
Now, do all hypertensives need a statin, like diabetics?
My impression is to put every patient with diabetes, every patient with hypertension on statin, because the safety of statin has been established. The efficacy of statin has been established. We have lakhs and lakhs of people on statin. I don't know why one should hesitate to put the patient on statin. Every time when the patient comes back to you with the muscle pain, stop the statin. You don't even realize that it was prescribed by somebody for an acute coronary syndrome, 80 milligram. You reduce it to 10 milligram. I think these are the things which should be avoided. Not that I am very, very knowledgeable and trying to probably think that you are not aware of all those things. You are already aware, but I would like to tell you that we should change our practice. We should change our approach in managing people with
So your message will
statin.
be, when somebody is a candidate for high dose statins, continue lifelong, or after a year or two, you just taper the dose, and then if the target LDL is achieved.
No, I don't, even if I reach the target level, I don't stop the statin, I don't reduce the dose of statin, as long as the patient is not having any problem related to statin therapy. High dose statin, when it is started for an appropriate condition, I think it has to be continued for lifelong.
What about the dual therapy, Narasingan? You only give statin, or you give statin plus ezetimibe?
Statin plus ezetimibe in case the patient is not responding to the so-called moderate dose or so-called acceptable tolerable dose or so-called high dose statin, you have already started. The patient is at high risk, he is not responding, he is not reaching the goal what you want in acute coronary syndrome, less than 50, you add.
But that's a trial, Narasingan, improve
10
it.
milligram.
Even with the pravastatin, when they combined ezetimibe, the outcome was much better than just giving a high dose of high intensity statin.
Absolutely, I was about to raise the same point, because previously when we talked about ezetimibe, we always thought it's a mechanical barrier to the cholesterol absorption. But this trial has proven that it is something much more than just the LDL cholesterol lowering.
Time will again start the dual therapy.
So that being the case, why not the clinicians incorporate ezetimibe? For example, instead of giving rosuvastatin 20 milligram, if rosuvastatin 10 and ezetimibe 10 can do the same job, and both have the data and the trial to back it up with a very good outcome data.
My suggestion will be, if the patient has got an acute coronary syndrome or a very high risk, don't reduce the dose of statin.
Okay.
If it's not reaching the level what you want for that particular individual, you add an ezetimibe.
Okay.
In case you have started a moderate dose statin in a comfortable patient with no other comorbid condition, fellow is not reaching the LDL goal, add ezetimibe. Ezetimibe will do wonders, because IMPROVE-IT study has shown remarkable improvement in cardiovascular risk reduction. The LDL cholesterol came down to 53 milligrams.
What about the pembedaic acid? Now I think after the CLEAR study, it has shown a very good outcome of LDL cholesterol levels, almost by 40%, and the cardiovascular mortality has improved.
So we are running out of time. I think I would like you to focus on two aspects quickly before my co-chairman Aarti sums up the discussion.
Not opening at all. Aarti?
No, she is going to sum up. That's what the agreement between us. Now, I want you to talk about the triglycerides. When do you target the triglyceride, to what level, which population, by what molecules, briefly? And also, do you target HDL at all? Very briefly.
Triglyceride is a big problem even in people with diabetes. Type 2 diabetic people also have very high triglyceride levels. When their sugars are under good control, the triglyceride level comes down, but may not touch to normal levels. You need to realize what is the exact level. If it is more than 150 milligrams, you need to be careful. 150 to 499. Adopt lifestyle changes. Think about the secondary causes for hypertriglyceridemia. You are probably missing some case of hypothyroidism or some kidney problem. Try to treat that particular aspect of it. Fellow is not responding, dietary modification, less carbohydrate, exercise, this, that. With that, patient should become all. At the same time, calculate the LDL cholesterol or do a LDL cholesterol direct method. If it is raised, LDL cholesterol, that means you need to put the patient on a statin. Statin will take the job of reducing your triglyceride also. Because we don't have enough studies to say statins are doing wonderful things only for triglyceride, because people were not focusing on that. They were all focusing only on LDL all the time. We know that it is also reducing the triglyceride. So 150 to 499 statin. Fellow is not responding to LDL, add ezetimibe even then. If you're not responding, add a fibrate at that stage or omega-3 fatty acid. Even if the patient goes beyond 500 to 1000, the pancreatitis problem may occur. So you should use the fibrate first, later omega-3 fatty acid. Do the LDL cholesterol very high. At that stage, you should try to introduce statin. The drug that has been introduced in the recent past, I don't know, Dr. Venkateswaran will be knowing it, not Venkatram will be knowing it, because I go to a hypertension forum where I talk to Dr. Venkateswaran, you are Venkatraman. So I have not realized that it is the diabetes forum. So the no, not bempedoic acid. This triglyceride reduction, reduce it trial. This trial has shown using icosopenteethyl ester, 2 grams in the morning, 2 grams in the evening, given to people who had already reached the LDL cholesterol goal of less than 70, with diabetes, without diabetes, with established coronary artery disease, and the cholesterol triglyceride level between 175 to 499. They were all recruited for the study. They had a follow-up of 4.2 years. Remarkable reduction. The primary endpoints came down by 25%. The secondary endpoints came down by 26%. So using icosopenteethyl ester brings down the cardiovascular risk. Is it by reducing the triglyceride? No. Because only 30% of the people had shown reduction of triglyceride. Rest of them were not showing. What does it mean? It means there is some pleiotropic effect by this drug. Pleiotropic effects are being seen. Endothelial function improves, is anti-atherogenic. Yeah, there are so many things.
I think Narasingan, the point is, the elevated triglyceride, is it a cardiovascular risk? Do you have any evidence? Number one. Number two, by reducing triglyceride, are you going to bring down the CV risk? Straight away come to the point.
What I'm trying to tell you now, there are studies which had correlated the cardiovascular risk with increasing triglycerides. Number of studies are there, ApoC3 and all those things. People are now trying to investigate some drug which will act only on ApoC3, which probably may be in the pipeline and we may get it after some time. But what is available today is to use the drug that is available even in our country, that icosopenteethyl ester, which I am using it for my patient. 2 grams in the morning, 2 grams. Start with the 1 gram, then 2 grams in the morning, 2 grams. That reduces the triglyceride to a remarkable extent. Please remember that you should use that in addition to your usual drugs of statin. Saroglitazar. Saroglitazar everywhere. No, we get the same question and the same answer. I think he is the correct person who has used in many patients. Please.
Yeah, it really helps to bring down the liver fat. Fatty liver is one of the wonderful drug. If you really add saroglitazar, and it really reduces the triglycerides, but we have no trial to prove that it is going to have a cardiovascular benefit outcome. We need a larger studies, but otherwise it's a very safe drug. It also reduces the blood sugar. The A1C reduction is 0.3%.
Absolutely.
So also acts on the PPR gamma and alpha. I think one point is that fenofibrate, I think slowly going out of market.
One point I wanted to ask. In fact, the quantum of triglyceride reduction, I'm sure you'll agree, all of us are using saroglitazar. The amount of TGL reduction achieved with saroglitazar is phenomenal. I would say, even from, of course, some people walk to you with uncontrolled diabetes. To what extent the good diabetic control would have reduced the triglyceride? That is speculative.
Use it for fatty liver. It's beautiful drug.
Yeah. And number two, as you rightly said, the effect on the glucose metabolism.
Cardiovascular outcome data. The drug is there for the past 7 years or 8 years. You don't have any cardiovascular outcome data. Without
That's
that,
why
how
I
can
asked
go
you
on?
the question. Triglycerides have always been identified as a marker, but is it a parameter to be targeted for the cardiovascular outcome? That I think that is the thing that's
field
boiling.
trial-
I don't think we have the answer.
At this stage, if you permit me to answer this particular question, I may have to take another 2 minutes, if you permit me to.
Oh, sure, please.
Whenever the triglycerides are going up, remember the triglyceride-rich lipoprotein particles are going up. The lipoprotein particles, TGRLP, are very, very important. There's a remnant cholesterol. How do you calculate remnant cholesterol? Total cholesterol minus HDL cholesterol, you get non-HDL cholesterol. From this non-HDL cholesterol, remove the LDL also. Then what is remaining is remnant cholesterol. So in my laboratory report, I always mention about remnant cholesterol. If the remnant cholesterol is high, more than 20, that means it is the starting point. Those patients with the triglyceride rise, with the remnant particle rise, they are the people who are at high cardiovascular risk. You need to remember that. Is there a data? Yes. The remnant cholesterols have been brought down even in the reduced trial. The reduced trial not only reduced the triglyceride in some segment of the people, triglyceride-rich particles had come down. In addition, the CRP levels are also coming down by usage of this particular molecule, icosopen ethyl ester. So CRP levels are coming down. So we are reaching this sort of what I can say exciting area where you can concentrate on the triglyceride-rich lipoprotein particles or the remnant particles. It has been correlated well with the cardiovascular risk. It's not the LDL, it is the VLDL cholesterol and not the VLDL triglyceride are important in increasing the cardiovascular risk.
A lot of articles on pitavastatin, especially targeting on cholesterol remnants, much better than LDL cholesterol. I don't know whether you have seen it or not.
So I'm not very much aware, Lakshman. I'm
Yeah,
not very much aware. PCSK9 inhibitor. Yeah, it is a wonderful molecule, monoclonal antibody, which is against the PCSK9. The Vijayakumar was the drug which was used in a 4-year trial, and then the Alirocumab was used in the Odyssey trial. Both the drugs are very good drugs. Alirocumab yet to arrive at Indian market. Vijayakumar, I am also using it, Vijayakumar. I have used it even for homozygous familial hypercholesteremia. My patient who had about 700 milligrams of LDL cholesterol came down to 520 with the high dose statin ezetimibe. With all these measures, nothing had happened. She lost her sister also. She did not respond to any of this treatment. Ezetimibe, everything added. They were not able to afford PCSK9 inhibitor. Through our lipid association, we were sponsoring 50% of the amount. So she is buying it every month, now taking it. Even after PCSK9, the LDL cholesterol was 230. So what I did, now I added bempedoic acid. Surprisingly, now it is 181. 181, after giving all sorts of drugs at my disposal, I have used it for my homozygous familial hypercholesteremic patient.
The combination has come. Statin plus bempedoic acid already come to the market. Yeah.
Thank you, sirs.
Yeah.